Crohn's disease is a chronic inflammatory disease characterized by transmural granulomatous inflammation, which occurs as an inappropriate immune response to abnormal gut bacteria in a genetically susceptible person, which releases inflammatory mediators which cause tissue damage. One important thing to remember is that it can involve any part of the gastrointestinal tract from the mouth to the anus, and in order of frequency, it goes from the terminal ileum with the right-sided colon, or in the colon alone, or in the terminal ileum alone, or the ileum and jejunum. Another thing is that the lesions are transmural, meaning they go from the mucosa all the way to the serosa. These are deep ulcers which form linear fissures, which gives the intestinal mucosa a cobblestone appearance, which is basically a normal tissue between patchy, ulcerated, inflamed tissue, which can further complicate into abscess formation and fistula formation. Some associated factors involved with Crohn's are that it's slightly more predominant in females, it's more common in Ashkenazi Jews. Not to IRGM, ATG16L1 are the culprits. Smoking increases incidence by 3 to 4 times, NSAID may exacerbate the disease, and abnormal gut flora are also a key player. Some factors which indicate poor prognosis in a patient are if the patient is older than 40, they need steroids on the first presentation, they have perianal disease from the start, they have isolated terminal ileitis, and smoking. The patient may present to you with abdominal pain, diarrhea which isn't bloody, subacute and acute intestinal obstruction, perianal abscesses, fistula and skin tags, anal strictures, glossitis. The patient may be anemic, they may have angular stomatitis, they may show up with weight loss and some basic symptoms like fatigue, malaise, and fever. If this goes unchecked, the patient may complicate into small bowel obstruction. There may be toxic dilatation, which is a diameter of more than 6 centimeters. They may show abscess formation, fistula formation, it may perforate, colonic cancer may occur, primary sclerosing cholangitis may occur, and the patient will end up with malnutrition. Some of the important differentials to rule out are cecal carcinoma, appendix abscess, infections which include TB, Yersinia, and actinomycosis, and these need to be ruled out before planning further management. When diagnosing such a patient, we do the basic blood labs like full blood count, erythrocyte sedimentation, C-reactive protein, urea electrolytes, liver function test, INR, ferritin, total iron binding capacity, B12 and folate levels. We do the stool culture to rule out C. difficile, Campylobacter, and E. coli. Then we do the fecal calprotectin, which is a non-invasive test for GI inflammation. We do a colonoscopy and biopsy even if the mucosa apparently seems normal. Then we proceed to small bowel imaging, which includes a capsule endoscopy where we give the patient a pill-like camera to swallow. But before this, we give a patency capsule which disintegrates on its own if it gets stuck in some obstruction of sorts. And we do an MRI and ultrasound. When managing such a patient, the basic principle is to induce remission. We have steroid-free maintenance for the patient so that the patient may have normal quality of life, and we do monitoring. When inducing remission in patients with ileal disease, budesonide is the drug of choice as it doesn't cause as much systemic toxicity. If the patient fails to respond within 2 weeks, we label it as mild to moderate Crohn's and we start giving the patient oral steroids, which we taper by 5 mg per week. If the patient is refractory to this treatment, the patient relapses on taper and there are more than 2 courses needed per year, we move to immunomodulators like azathioprine or 6-mercaptopurine. As an alternate to glucocorticoid therapy, we may induce remission through an elemental diet or a polymeric diet. If the patient still fails to respond, this is labeled as severe Crohn's and we move to aggressive IV hydration and electrolyte replacement. Then we further give IV steroids, including hydrocortisone and methylprednisolone. Then we do thromboembolism prophylaxis as the patient is more susceptible. Moving from this, we monitor the patient. We monitor their temperature, pulse rate, BP, stool frequency. We do a daily physical exam, all the blood labs, and a plain abdominal x-ray. If hemoglobin is less than 80 grams per liter, we transfuse blood and manage the nutrition properly. Is the patient improving? Yes, then we downgrade to oral prednisolone again. If not, then biologics have a role, which include anti-TNF-alpha drugs like infliximab and adalimumab, or anti-alpha-4 beta-7 integrins, which are monoclonal antibodies, and we give anti-interleukin 12 and 23s, which include ustekinumab. If it still doesn't respond, consider abdominal sepsis as a complication, especially in patients with severe abdominal pain. We do an ultrasound abdomen, a CT, and an MRI to rule this out. In case of perianal disease, this occurs in 50% of the patients. Examination is done under anesthesia and an MRI may or may not be done. The treatments include oral antibiotics, immunosuppression, which may or may not involve anti-TNFs, and local surgery with or without ceton insertion. Thanks for watching, you guys. You can go check out more videos on the channel. Do leave a like and subscribe for more content like this. If you have any questions or suggestions, you can leave a comment down below. I'll see you next time.